So let me look at the first question that we are seeing here, the last line. Which of the following is true about this child? So basically they have asked an inherited qualitative hemoglobinopathy, inherited quantitative hemoglobinopathy, inherited enzymopathy, inherited cytoskeletal defect. Looking at this, examiner is asking about inherited hemolytic anemias. Let me start with the question. 8-year child presents with abdominal pain. So there has been abdominal pain. The pain is located in the right hypochondrium. So right hypochondrial pain, query I can suspect, query liver pain, query gallbladder pain can be there, right? The pain is colicky, disappears after a few minutes. So basically it's a colicky pain. Ultrasound shows gallstone. So basically whatever I was suspecting, that is now clear for me. There is a gallstone suggestive of hemolysis then. So patient is having hemolytic anemia. So there is a hemolytic anemia and there is a shrunken spleen. This is the keyword given to me. So gallstone is hemolytic anemia, shrunken spleen. I am suspecting sickle cell. Straight away I am suspecting sickle cell, which is a qualitative hemoglobinopathy. Option A, qualitative hemoglobinopathy. Rest of the physical examination is normal. Peripheral smear shows abnormal shaped RBCs. That is all again for sickle. So diagnosis here is sickle cell anemia, and we are suspecting this is a qualitative hemoglobinopathy. That is the answer here, right? Yes. So was an easy question. There were only two keywords, or one keyword I would say in this. Last line again, let me look. Which of the following is appropriate diagnosis? And there is an image given to us, and option given are hyaline arteriosclerosis, Kimmelston-Wilson lesion, Monkeberg medial sclerosis, polyarteritis nodosa. 4 options are given. Let us look at the question then, and there is an image also given. Let us look at the question. Question: 50-year-old woman with type 2 diabetes and hypertension. So she is having both hypertension and type 2 diabetes, and this is the renal biopsy for a chronic renal disease. So this is what it is. Now let us look what is it. First thing, it is not Kimmelston-Wilson lesion. Why? Because Kimmelston-Wilson lesion will be happening in the glomeruli. I don't see glomeruli here at all. So Kimmelston would have been in a glomerular disease, and that is not Monkeberg medial sclerosis. Usually that happens in the old age, not at 50 years of age. Not polyarteritis nodosa, because it will be associated with hepatitis B. Answer is hyaline arteriosclerosis. So what you are seeing here is pink material seen in the vessel wall. This is your hyaline material that is seen, hyaline arteriosclerosis. So basically we had to only differentiate KW lesion from hyaline arteriosclerosis here, because the history was given, and hyaline arteriosclerosis can be seen in hypertensive changes. So this is your due to hypertension that you are seeing here. Next, let us look at the next question. Okay, lengthy one, the last line again. Which of the following is a likely diagnosis? So there is a image given, likely diagnosis has been asked. Option given are adult granulosa cell tumor, embryonal carcinoma, thecoma, sertoli-lytic tumor. Definitely I don't see it is not an embryonal carcinoma looking at this, because embryonal carcinoma will be having more pleomorphic nuclei. Anyway, let me look at the question, then it will help me out. This is a pictograph, shows a high power view of an ovarian tumor from a 30-year-old woman. So it is a 30-year-old woman who presented with abnormal uterine bleeding and abdominal pain. The neoplastic cells are immunoreactive for inhibin. This is the keyword given. Inhibin is a marker for granulosa cell tumor. Simple. So that was the keyword. Answer will be granulosa cell tumor, and it is in 30-year. So this will be an adult granulosa cell tumor. Of course, granulosa cell tumor can occur even in childhood as well. Anyway, so this is a granulosa cell tumor. Sertoli-lytic tumor, no, this is not. In sertoli-lytic tumor, you might see Rinke's crystals, etc. Thecoma, fibroma, again, not. It will not have inhibin as a marker, right? Yes, next question. Let us look at the next question now. So next question, again the last line. Which of the following investigations will not help in arriving at a diagnosis? Question says will not help. So which is not useful investigation? Bone marrow examination, portal venous pressure measurement, cytogenetic examination, serum erythropoietin. Let me look at the question. 48-year-old male presents with recurrent infection, jaundice and bloated abdomen. So he's having recurrent infection, jaundice, bloated abdomen. Clinical examination shows hepatosplenomegaly and ascites. So there is hepatosplenomegaly, ascites. USG shows a thrombus in hepatic vein. So there is a thrombus that is seen in the hepatic vein. Liver is edematous as well. And a blood examination shows hematocrit of 52. That is what is the keyword. Hemoglobin is 18.5. This is nothing but polycythemia. So now we understand patient is having polycythemia. So he can be having a polycythemia vera or maybe a secondary polycythemia, whatever is it. So I have to look for erythropoietin to differentiate. This is required. So this is required, not the answer then, because we require. So it is required for diagnosis. Cytogenetic examination is also required for diagnosis, because if you are suspecting a polycythemia vera, you need to do that. Bone marrow examination is also required. For diagnosis, portal venous pressure measurement will not help us. Although we are expecting portal hypertension to happen, but that's not going to help in diagnosis here, right? Yes. So next question, let us look at next question, little bit lengthy one. Last line I will start. Which of the following investigation would most likely help in arriving at diagnosis? So options given are bone marrow aspirate, flow cytometry, JAK2 mutation analysis, echocardiography. Which will help in arriving at diagnosis? Most appropriate, most likely. Let us look. 35-year male is been passing frequent dark colored urine for last 1 month. The moment there is a dark colored urine, this is definitely what? Intravascular hemolysis is happening. So there is an intravascular hemolysis. The episodes occurs anytime during the day without time preference. Since then he has developed easy fatigability and yellowish discoloration of sclera, which is again suggestive of hemolysis basically. So patient is having a hemolytic anemia and easy fatigability is anemia. So patient is having intravascular hemolytic anemia now. That is my diagnosis. So intravascular hemolytic anemia. Now he has a difficulty in moving his left upper limb. So there is a difficulty in moving left upper limb. CT brain shows a thrombus. So basically an intravascular hemolytic anemia, I can say hemolytic anemia plus thrombosis is there. Thrombosis is there. Abdominal examination shows no organomegaly. Hemogram shows hemoglobin 8 expected, anemia is there, MCV is 70, MCH is 25, peripheral smear shows microcytic hypochromic anemia, platelet count is low, thrombocytopenia is there. So patient is having a typical triad of PNH, and for diagnosis of PNH, it is your flow cytometry, that is the investigation of choice. Gold standard investigation is flow cytometry. The other things are not helpful at all for us to make anything as a diagnosis of PNH. Clear? Yes. So next question, let us look at the next question here. Okay, last line. Which of the following is the most likely diagnosis is the question. Option given are acute pyelonephritis, acute cystitis, malakoplakia, urothelial carcinoma of bladder. So 4 options. Let me read the question. 36-year-old woman has urinary frequency with dysuria for past 4 days. Increased urinary frequency, query UTI, query pyelonephritis and acute pyelonephritis with the history, right? And on physical examination, she has no flank pain or tenderness. Most likely rules of the pyelonephritis, because pyelonephritis, the inflammation would be going to kidney. There will be a renal angle tenderness usually happening. Urine analysis, a specific gravity of 1040, pH 7.5, no glucose, no protein, no blood. Nitrate test is positive, suggestive of infection. So there is an infection, most commonly E. coli. There are many WBCs seen. So very important is no flank pain is ruling out acute pyelonephritis. Also, if it was a pyelonephritis, you would have seen a WBC cast as well. That is not given. So it is not acute pyelonephritis. Answer is it is a acute cystitis, which is a part of your urinary tract infection. It is not malakoplikia. Malakoplikia is a chronic condition where there will be Michaelis-Guttman bodies that will be seen, and definitely not urothelial carcinoma. It should be having more hematuria in the urine examination. Next question, repeat question of this in CBT as well. Intentionally I kept that repeat. Okay, let us look and slight variation. Of course, in exam you get repeat questions sometimes, and the idea here is checking whether you are making the correct diagnosis. A 22-year soccer player suddenly collapses on field during practice match. He died on the way to the hospital. The autopsy is as shown. Which of the following mutation can be seen in this patient? So only the question changed is mutation. I'm sure all of you made a diagnosis. HOCM is your diagnosis in this. Yes, so which mutation will be seen? Placoglobin. No, placoglobin mutation is seen in arrhythmogenic right ventricular dilated cardiomyopathy. That is dystrophin is no. Dystrophin mutation will be seen in muscular dystrophies, which can cause dilated cardiomyopathy. Myosin heavy chain mutation is the one. Fibrillin is also no, seen in Marfan syndrome. Myosin heavy chain mutation or MYH mutations, or even myosin binding protein C mutations, alpha troponin mutations also can be seen there in HOCM. Next question, last line. A biopsy from lung is as below. What is a likely treatment? So this is a lung biopsy, and what is a likely treatment has been asked. And option given are anti-tubercular therapy, surgical resection, steroids, palliative therapy. So 4 options are given to us. I can see something here. Okay, first thing is, remember, palliative therapy will be only given if it is a cancer. I don't see any cancer here. I rule it out because no neoplasia that I am seeing. And what I am seeing here is, of course, I am saying this is a granuloma. There are multiple granulomas that are formed here. I can see all these are granulomas, by the way. Yes, these are all granulomas, and I don't see any caseous necrosis. So let me look at the question, then we'll make a diagnosis better, I guess. A 46-year-old, and anyway, for granuloma, surgical resection will also be the wrong answer. Surgical resection will also be treatment only if it is a cancer, right? So I don't see any neoplasia here. Let me check what is the question. 46-year-old chronic smoker presents with cough, intermittent fever for many weeks. So he's having, he also complains recent hoarseness of voice, and he's having cough. He's lost 6 kgs weight after onset of symptoms, which looks like malignancy. Sarcoidosis and tuberculosis both can be DDs for malignancies, and both of them can have granulomas. Chest X-ray shows calcified lung lesion with few hilar lymphadenopathy. Serum calcium levels are increased. Clinically, calcium levels are increased. This is a keyword which is in favor of sarcoidosis, not in favor of tuberculosis. In sarcoidosis, because of increase in vitamin D, there will be hypercalcemia happening, and there are non-caseating granulomas. So answer here will be steroids, not anti-tubercular therapy. Right? Next question, question number 9. Not very lengthy, but anyway, last line. What is a likely diagnosis? And there is an image given, and option given are A beta lipoproteinemia, Whipple disease, celiac disease, and tropical sprue. So I definitely can see this is the tall villus that is there. Villi are tall, so it is not a celiac disease straight away, right? Villi are tall and not a celiac disease. And the epithelium is not showing any fat. That is why it is not A beta lipoproteinemia also. Now the lamina propria, look at this. This is showing foamy macrophages. There are foamy macrophages seen in lamina propria, which is characteristic of Whipple disease, and that is what is I am suspecting. Let me look at the question then. So the question is, 43-year-old presents with abdominal pain, nausea, vomiting, diarrhea, weight loss of 6 kg in the past 4 weeks. So basically there's a malabsorption syndrome happening. The HLA-B27 male has been receiving therapy for polyarthropathy. So he's having a arthropathy for the last 5 years, which is partially under control. So actually he has been treated as a HLA-B27 autoimmune condition, and he has been treated, and now he is having Whipple's. Actually Whipple's can have extra intestinal manifestation. This possibly could be extra intestinal manifestations of Whipple's in the form of arthritis. So anyway, that is not keyword here. The keyword is the image itself, which is Whipple disease. Whipple disease. Tropherema whippleyi is the infectious agent causing it. Next, question 10. Which of the following is true about this patient? True about this patient is asked. Let us look at then there is an image given. We are able to identify all this image is showing these cells, atypical cells. These are hairy cells, if you can identify. Anyway, if you are not able to identify, always look for options. It will help you out. All trans retinoic acid is a treatment of this choice for this. This will be seen given in acute promyelocytic leukemia. That is not the case here. The patient is having an aplastic anemia. That is not the case. The patient is having a peripheral B-cell neoplasm. That will be the answer. Bortezomib is one of the treatment. That is not case. Bortezomib is used in multiple myelomas. It is used in multiple myeloma, bortezomib. So let me look at the question then. If you have not made a diagnosis on peripheral smear, look at the question. 53-year-old presents with easy fatigue, repeated sinopulmonary infection for last few months. Clinical examination, spleen is enlarged. This is a keyword. When splenomegaly is there, this rules out aplastic anemia. It cannot be aplastic anemia because of splenomegaly. In aplastic anemia, there will be no splenomegaly, remember this. And no lymph nodes are palpable. CBC is hemoglobin 9. TLC normal, platelet count, pancytopenia is there basically, and peripheral blood examination is as shown. So now you have to make a diagnosis. Aplastic is ruled out straight away. Bortezomib is also ruled out because multiple myeloma. So all trans retinoic acid is also ruled out because APML will show blasts with or rods. That is not the case here. So answer is option C. It's a peripheral B-cell neoplasm, hairy cell leukemia. Next question, let us look at the last, only one liner, so I can straight away. A medical student is describing histology of anaplastic carcinoma of thyroid. Which of the following histological feature is not applicable for the features of anaplasia? Not applicable is question. Capsular invasion, nuclear pleomorphism, abnormal mitosis, high nucleocytoplasmic ratio. Answer is a capsular invasion. Invasion is nothing to do with anaplasia. Anaplasia features will be nuclear pleomorphism, abnormal mitosis, high nucleocytoplasmic ratio are features of anaplasia. Right? Yes. Next question, last line. Which of the following best explain manifestation in the patient? So some manifestations are given. What is explaining the manifestations? So let us look what is the excessive production of TNF alpha, Warburg effect in tumor cell, metastasis to hunger center of the brain, reduced volume of the stomach due to local effects. 4 options are given. Let me check what is the question. 53-year-old chronic smoker presents with 10 kg weight loss in the last 4 weeks. He complains of reduced appetite and is physically appears to be wasted. A CT lung showed mass in the periphery of the lung. So there is a tumor seen in the periphery of the lung. There will be a carcinoma of lung. Query adenocarcinoma, I can say. So adenocarcinoma, although he is a smoker, that is the only one thing against adenocarcinoma. Peripherally located tumor are adenocarcinomas. Anyway, for me it is not diagnosis, which explains the manifestation. The manifestation this patient is having is reduced appetite and also wasting. This is called cachexia. Cancer cachexia happens due to TNF alpha released. This is called cancer cachexin. TNF alpha is called cachexin, which is causing the manifestations of cachexia. So due to constant death of the tumor cells, there will be release of chronic inflammatory mediators like TNF alpha, which will lead to this. Next question, question number 13. One liner question: the function and mechanism of action of thrombomodulin in normal hemostasis is. So what is the action of thrombomodulin? What does it do? Activation of protein C, activation of antithrombin, activation of plasminogen, activation of factor 10. Thrombomodulin is going to help in activation of protein C, remember. So what is this protein C? So basically thrombomodulin is, antithrombin is stimulated by thrombin and plasminogen actor. So basically your so thrombomodulin will activate your protein C, and protein C is going to inhibit your coagulation, naturally occurring anticoagulant. So antithrombin is not activated by thrombomodulin. Antithrombin is stimulated by the thrombin itself. And activation of plasminogen is done by tissue plasminogen activators. Okay, so answer is option A, activation of protein C. Thrombomodulin will help in activation of protein C. So next question, let us look at this. What is this question saying? Last line: which of the following immunological abnormality is she most likely to have? So cell mediated hypersensitivity, localized anaphylaxis, immune complex mediated, antibody mediated. Let us look at the question now. 15-year-old girl with no major medical problems notes blotchy areas of erythema that are pruritic over skin, legs, trunk. Within an hour she eats seafood. So basically there is multiple rashes in the skin after seafood, which is a type 1 hypersensitivity reaction. Simple. So it is a type 1 allergic reaction, which is also called localized anaphylaxis. Localized anaphylaxis. You might even develop anaphylaxis on a later date as well. Not on a later date, on any time of these episodes. Okay, and let me see further. Followed by diarrhea also. The problem is problem abate within 3 hours, and then physical examination reveals no abnormal finding after that. This is histamine, typical histamine mediated increased vascular permeability and vasodilation. That's where redness as well as the diarrhea is happening. Next question, the last line I want to look at. What is the question? Okay. So microscopically there is abundant pink hyaline material in the glomeruli and around the small vessels. That is what has been given. What will be the blood investigation? What will be true question has been asked. An increase in IgG levels, increase in PSA level, increase in erythropoietin, positive anti-nuclear antibody. So basically 4 different options are given. 62-year-old man had back pain for 8 months. So he is having back pain. Productive cough for past 2 days. Physical examination, temperature 39. So he's having infectious condition. There is dullness to percussion in the right lung base. So possibly pneumonia. Chest x-ray shows right lower lobe consolidation. Diagnosis of pneumonia. So patient is having pneumonia, 62-year-old. Abdominal CT shows multiple lytic lesions of vertebra. So there are lytic lesions in the vertebra, and there is a recurrent infection happening in a 62-year-old. 1 day prior to his death, serum urea nitrogen 63, creatinine 7.1. So there is a renal failure. Evidence of a renal failure is there. Dipstick urine analysis was normal. At autopsy, kidneys are firm and pale, and microscopically abundant pink hyaline material is seen. This is suggestive of amyloid. So history is suggestive of amyloidosis of kidney with multiple lytic lesion, multiple myeloma. Primary amyloidosis is my diagnosis. So what will be found? Increase in immunoglobulin levels is the correct answer, because there will be a hypergammaglobulinemia. There will be a monoclonal gammopathy, and most common M protein is IgG protein will be there. Increase in PSA level will be seen in either prostatitis or a prostatic carcinoma, which can also cause lytic lesion, but there should have been history of urinary retention or any other thing which can cause prostatic carcinoma can cause lytic lesion because of metastasis, by the way. Increase erythropoietin and not the answer, because polycythemia, nothing to do with bone. Positive anti-nuclear antibody will be a lupus, right? So answer is option A here. Option A is the correct answer that will be seen in this patient. So these were questions from pathology. I think it was a mixed bag this time. Slightly 15th one was slightly tough. Few of them were tough, but most of the questions were easy. So I hope all of you have got most of the questions here. Best wishes all of you, and keep putting your efforts for betterment every day.